Welcome to the webinar 10 Mishaps with Implant Overdentures, Strategies to Manage Them and How to Avoid Them. The lecture is being presented by Dr. Dana Marzocco, DMD, and we will begin shortly. And with that, it is my distinct honor to introduce Dr. Dana Marzocco, DMD. She grew up on Long Island and earned her doctorate from Tufts University School of Dental Medicine. After a general practice residency at Montefiore Medical Center, she completed postgraduate prosthodontics training and a 2-year implant fellowship at NYU. Now in private practice in New Hyde Park and Fresh Meadows, Dr. Marzocco is a clinical assistant professor at Stony Brook University Dental School and lectures on implant restoration. And now it is my honor to say, take it away, Dr. Marzocco.
All right, thank you. Jessica, my screen is okay, right? The intro slide?
Yes, it is.
Okay, great. Okay. Hi, everybody. Thank you so much for coming in and listening to us tonight. So what we wanted to do is put together a lecture about implant overdentures, but with an hour, it doesn't allow us to cover the whole complete topic. So we wanted to focus on some of the complications that happen with the prosthesis. So the next 45 minutes, 50 minutes to an hour, we're gonna touch on that. So you heard this about me. I am a prosthodontist. I'm in a prosthodontically driven practice in Long Island, New York. I practice with another prosthodontist. I'm there during the week, and then one day a week I teach at Stony Brook University, which is in Eastern Long Island, about an hour east of me. For your reference, the school's about 2 hours east of Manhattan. So you can see here where I went to school, all the places I've trained, and where I teach now. So what we want to focus on tonight is some of the complications associated with the implant overdentures. In this lecture, you'll see a lot of unsplinted implant overdentures. We'll touch a little bit on some of the other attachments, also implants that are supported by a bar overdenture. Again, you'll see more focus on the unsplinted. I think that is where more of the complications, at least that in my office, that come through, they're associated with that. So what I did is put together a slide set, kind of highlighting just like 10 of the issues I see. Again, this is just what has come through. My office is not completely inclusive, but I put in here everything that I've encountered. So we all have these patients in our practice, right? Patients can come in with an existing overdenture. You can have a new patient that is coming in, you're going to treatment plan an overdenture, or perhaps you have this patient in your practice already that you've been seeing, a denture patient, and you've talked to them about upgrading their prosthesis to an implant-supported prosthesis. So those are the kind of 3 segments of people that have walked into my office. So again, we're just going to get right into it. We don't have a lot of time. And again, any questions, we'll take all of those at the end. So let's talk about the first situation that I've seen. So if you have seen a patient with a mandibular implant overdenture, in particular a 2 implant overdenture, and what they will do is have their chief complaint is that the denture will be rocking. There's too much movement. So what's going on here? That can be attributed to the position of the implant, maybe the number of the implants, and also the big thing is how is that tissue adaptation? If this is an older prosthesis, if this is a patient who came into your office with this existing, this is also something to examine. So as we go through all these things that come up that we've talked about, complications, you'll see a lot of them overlap in issues. Some of them overlap in issues, and you're probably going to hear me repeat things because some of them are common issues with other problems. So again, if you look at this denture, if you remember back to the McGill consensus, I don't recall the year right now, but that article that came out, what they were suggesting was this standard of care should now be the 2 implant overdenture. This was a number of years ago. And since that I've been in practice, since I've been a resident, that has always been the go-to treatment plan for a lower edentulous patient. And then we can talk about how that has changed, over time, or at least my opinion of that has changed over time. So here we are, we have this denture, rocking movement. At this point, something you want to consider is look at the implant positioning. If this is this is a lot easier to address if you were the dentist to prescribe this treatment. Again, look at the denture base. It might be time for a reline. If this prosthesis is old, It might need like a spot hard reline of the intaglio surface. When I fabricate these types of prosthesis, I like to fabricate them with the framework and tissue stops, and you'll see a picture of that coming up. The reason for that is it's going to prevent any type of fracture. And if you have something that has a tissue stop, you can also recall the point where your denture was, meaning if you have to adjust it, you're not going to be hollow out grinding the intaglio surface with your acrylic burr, particularly if you have metal there. Metal's going to give you a stop of how far you can drill, or how far you can cut back the acrylic. So let's talk about the implant positioning. In this particular situation, we're talking about the mandibular arch. So if you look to the left, you'll see I have this labeled as good, better, much better. These are the three most common situations that you will see. So on the left slide, there's the traditional 2 implant overdenture. Ideal positioning is in the canine spots, 22, 27. Why is that the ideal spot? That's where we have the thickness and volume of bone, both in a vertical and a horizontal position. So that's where the canine has the longest root form, and that's usually the most robust place where we can place the implant. So again, that's really the ideal situation. With this type of patient, is there going to be some rocking? Yes, of course. I think it's also important to manage your patient expectations. If you're going to treatment plan this type of restoration, the patient needs to be aware that there is going to be some movement of the prosthesis. It just kind of comes with it. There's really nothing you can do about that when you have 2 implant overdentures. So let's look at the center photo where we have 3 implants. You can see the center implant is slightly off the midline. The reason why I have that pictured like this is, as a prosthodontist, I'm always looking towards the future and what happens later on. What if this patient wants more implants? What if they want a fixed restoration? So if I have an implant right at the midline, you can see how managing that fixed restoration would be kind of difficult, and you'd be giving yourself some aesthetic challenges. So again, maybe we're hoping for something that will never happen, but I think a little bit of asymmetry in this point is not the worst thing. You certainly have AP spread, but I will tell you the addition of the 3rd implant is going to reduce that rocking tremendously. It just helps to resist the anterior posterior rocking. So let's look at the 4th slide. So now we have 4 implants. Think of this as a chair, right? Sitting on a chair with 3 legs, probably not so comfortable. Sitting on a 4-leg chair, that's stabilized here. So when you're treatment planning this, the other important thing to consider is what is in the opposing arch. If you have a patient with the denture, there's not a lot of occlusal forces there. So a patient could have 2, 3, or 4 implants, and they're going to function pretty well. If you have a patient that's dentate with the full complement of teeth, or a fixed implant restoration, particularly like a zirconia or a porcelain fused to metal, you can imagine when they go to occlude and they're occluding against a 2 implant overdenture, they're going to get a lot of rock in there. That person might get some advanced wear on the prosthesis. So in that situation, maybe a 4 implant is better. 4 implant overdenture is a better choice, I think. Does that always happen? Do I have that posterior bone? Unfortunately, not that often. But when I can, for me, that's the way to select the treatment for the patient. So as we spoke about, as you increase the amount of implants, you're going to increase the retention. As you have less implants, your movement is going to be more. So you're going to reduce that movement and increase that retention. So, let's go over this in a little more detail. If you look at this slide here, where I wrote it began with 2, because I'm referring to the McGill consensus, right? So part of this is also to look at the arch shape. If you have a patient who has a very wide, broad arch, and they only have 2 implants in the canine position, that's a giant cantilever. And the fulcrum line is way forward. So that's somebody who's going to have rocking. Where if you have a U-shaped arch or a V-shaped arch, you're probably going to see a little less rocking there. There's just going to be more stability because you're going to have not a sharp curve, but less of a broad curve. So if you look at the center picture, those 2 implants are positioned very close together. And that's what it looks like with the abutments on the bottom picture there. So as you can see here, this patient, I would expect there would be a lot of movement. So if this patient comes into your office with an existing implant overdenture that looks like this, and they're telling you the denture is moving, how much more are you going to be able to do with this? You're really limited to the implant positioning. So for this patient, is the stronger attachment going to help you? Not really. It's going to just address the retention. This might be somebody you might want to make a bar or a distal cantilever, or maybe add another implant. But it's important to manage their expectations, particularly in this case. So let's talk about when you have three, right? As we spoke about, the addition of that third implant is going to make a tremendous reduction in the movement. So less rotation, less rocking. It provides a significant amount of stability. And to me, when the patient is getting an implant restoration, this matches more of the expectations, I think, of what they expect to get. Okay, so let's look at 4. So in this particular case, you can see on the top picture, these are ball attachments, not locators. But again, just showing you this so you can see that there's different parts that are available out there. So are these 4 ideally placed? Certainly not. But when you have more implants, you're going to take down a lot of that rocky movement, keep it a little bit more stable, I think. And as we spoke about, I think you need to look at what's in the opposing arch and talk to the patient about that, about what you expect the movement to be on this and why you think either a 2 or 3 or 4 implant overdenture on the mandible is applicable to them. So in this lecture, we're mostly focusing on the mandibular overdenture, but we're going to touch on the maxillary prosthesis also. So again, I think the success is dependent here on the implant positioning. And based on the positioning, that'll help you choose whether you can do an unsplinted implant overdenture, or maybe you need a bar for that additional support, whether to reduce the cantilever or just to make up some of that vertical space that you're trying to fill. So let's look at the maxillary arch. So we have 4 different scenarios here. Is this every scenario that has come through my door? Certainly not. But these are the 4 that I've seen, and we can talk about the issues with all 4 of them. So we have a 2, and then we have a 4, and then we have a 6. So there's a bunch of ways you can go here. So let's go through each one of these. So let's talk about a patient that comes into your office like this. Let me just make one commentary here. These are just the scenarios that I have seen. So some of these patients might come to you already with these implants in position. That's one way to look at it. And what if you were starting from scratch? Reasons why you would or would not select one of these situations. So let's say a patient comes to you with integrated implants, 2 implants on the front. Excuse me. Let's say that the patient no longer has any funds to do any more implants, or perhaps they have something existing and they're having issues with it. So what's going on with this situation? Because of the position of those 2 implants, we certainly have a very large cantilever, right? We have movement in a multi-plane. Fulcrum is very anterior. So this patient, if this is someone you're going to restore in this situation, I think you need to have palatal coverage here, whether you have acrylic palatal coverage or maybe you even have a metal palate, which is probably even a better choice for this, just for additional strength. You're going to need that metal support to support the prosthesis. And if you look at this and you say, well, why would you ever treatment plan this? I always say, what if you have a disabled patient? What if you have a geriatric patient? Maybe somebody who is limited in removing and inserting their denture, or maybe they can't keep it in because they have a tongue thrust. This might be the patient for this situation. So is it something that I would treatment plan? No. In special situations, yes. And for somebody like that who might have limited dexterity, I certainly think that the addition of the 2 implants is better than having 0, right? Rather than relying on denture adhesive. This way, they're going to get the retention, right? So they might not get the support, but they're certainly going to get a lot more retention. So you're certainly doing a nice service for somebody. Not in the most ideal situation, but better than having 0. Okay, let's look at this situation. We have 6 implants, 3 bilaterally. So the question is, how much edentulous room do we have in the premaxilla? When I say that, I mean, how much space do we have from number 6 to 11? Is there a large premaxillar? Is that introducing giant cantilever in the anterior and the anterior and the posterior, as you can see. So arch shape will really determine what's going on here. So a situation like this, I would certainly fabricate something with a metal structure. A palatless overdenture would be fantastic with a metal frame. You can certainly have an open palate here. The problem with having 6 is it can be too retentive. So if you're going to use unsplinted abutments for this type of overdenture, maybe you want to lighten up on the attachment, right? You start with the lightest retentive element. You might even want to use a zero retention element, a non-retentive element like a stop on the middle implant on both sides if the patient is unable to remove the prosthesis. So you certainly need to pay, careful attention to the selection of the nylon retentive elements that you use, and it's really like a case-by-case situation. So let's look at this scenario here. So we have 4 implants. Everybody's in the anterior, right? So now here we are again with a cantilever. Our fulcrum line is way up front. Somebody like this, if you have the vertical space, so let's touch on that a little bit. For a traditional, abutment with the housing, you only need really a few millimeters, right? If you need a fixed restoration, you need more. If you need an implant overdenture, you need even more than that. So I think you need at least 12 to 15 millimeters, maybe even a little more, depending on how much substructure you have here. So you certainly could do a bar with 2 distal cantilevers here just to reduce some of the posterior cantilever, just to give it a little bit more support. So again, we go back to that question, is this ideal? No. But is this better than having nothing? I think so. But it all really lies in how you design your prosthesis. If you fabricated something like this with unsplinted abutments, with either locator abutments or a ball or ERA, I think you're really in danger of just rocking that denture and putting undue stress on the implants. I had a patient like this very early on in my career with this exact situation, unsplinted implants with an overdenture, and one by one we lost the implants. So it's nice to make the restoration, but we also have to not forget the physics of the implant that's underneath supporting it. So, here's our last situation. This has the most anterior posterior spread. We have a nice distribution of force in this situation. And again, think about what you're opposing. If this is reposing natural dentition, this is really the best setup, right? Somebody can chew, somebody can function. Sometimes with these prostheses, the patient will tell you, I bite and then it unlocks. And a lot of that is just uneven force distribution of the implants. And again, this is a nice scenario, but how often do we encounter this, right? So a little bit back to the tissue stops, which we spoke about here. You can see it in these images here. So again, the importance of the tissue stop is when the laboratory is fabricating the overdenture, the tissue stop keeps the frame from sitting directly on the tissue, so that when it's processed, whether it's traditional heat processing or injection molding, there is acrylic that flows underneath. That is important because if you need to adjust it, you won't be cutting into the metal. So I highly recommend that you make these prostheses with the frame, maxillary or mandibular. This is going to prevent fracture. And that is a big thing here. So if these prostheses fracture, you can't repair it. It's never the same. The integrity is really lost with it. So again, it's important that it's robust. And again, this is just an example. If you look in the bottom center picture, you'll see I have 5 implants crowded all in the front. So this is one of the other ones that came like that. If I could go back and do this, maybe I would have done a bar. Maybe I would have kept the palate in there. So that particular case is many years old, and that's why I have it in here so I can comment on what I had done in the past and what I would do if I saw this today. Okay, second thing, and we kind of touched on it a few minutes ago. What about dislodgement? When the patient is chewing, and then not one of the attachments pops, not one of the attachments pops, but the denture kind of pops out. Again, that could be related to the implant position, as we just spoke about in the first section. Sometimes that is related to the retentive elements, and sometimes that is the abutment. So we already covered the implant positionings. So it's important to look at the abutment, whether you have a ball abutment, whether you have a locator, something like this, or whether you have like a hater clip. It's always important to see what's going on. In this particular instance, locator has the name is escaping me right now. It has a tin coating on the outside, and once that gets worn down, you'll see the silver show through, and you can see it on the left implant there. You see those lines on there? That's all wear. And sometimes you can't see this when you look in the mouth with loupes. The light will just block it out so you miss it. If you suspect there's any wear on these attachments, I think it is important that you remove the attachment and look at it with your loops without the loop light because you will miss it. This also happens for the ball attachment, and it's very hard to see when the ball is worn because it's very small. Remember, these attachments are like 1.5, maybe 2 millimeters diameter at most. It's very hard to pick up if you have wear on a surface. So another thing you can do is you can scan it, which is what I did. I scanned it and I had my technician look at it on the virtual imaging and measure it. So he was able to tell me if it was worn. The locators are easier to see. The wear, the ball's a little harder. The other thing you can do is you can put a retentive element, a brand new one on there, and snap it on, snap it off, see if it still grabs. So if you have worn abutments, those obviously need to be changed. If your abutments are still intact, look at your nylons. Maybe the nylons need replacement. Depends on the patient, how many times they're inserting and removing this prosthesis over the course of a day, a week, a month. So you can see it right there, as we spoke about. Just another example of worn abutments where you see the silver show through. Once you start to see that, you've really lost your retention. And that's just it again, close up. So let's just touch on this real quick. So different types of attachments here. You have your traditional on the left, your extended range on the right. I really don't want to get into this because it's not really like a parts and pieces lecture. It's more of troubleshooting. But if you have questions, I can address those at the end. So we talked about the ball attachment. So what happens with the ball attachment is the head can wear and then you lose your retentive element and then it needs to be changed. I haven't seen that loosen up, mostly just wear. And that's like I don't want to say it's a simple swap out, but it's a swap out of a part. So if you have a locator housing and you see that it's spinning, meaning if you put a explorer in there and you try and rotate it and it moves around, now you know it is dislodged and separated from the acrylic. So what you see here is me using a burr to take it out. But now what I use is a nice trephine burr and that will remove it. And also the same thing with the ball attachment. That can be trephined out. So this is just an example here. So the way that you would handle this is you can place retentive grooves when you pick up the attachment. Again, whether it's this or whether the ball. You can place an undercut, retentive grooves, any of those type of things when you're picking that up again. So this just happens to be a kit that I have. Again, there's no other than in DX, we're not really working any partners tonight, but this is just something that I have in my office. Different types of burrs to make the wells. I think the most important one here is really the undercut well, and you can help to lock in the attachment. So again, this is what it should look like when you remove it with a trephine burr. You have a nice clean area where you can pick up the attachment again. Also, the other thing that's important is creating a vent space with a vent burr, like a lingual vent hole, which is in the bottom picture. In this case, it's very large because it's a demo model, but you kind of get the idea here. So the trephine is nice to remove whatever element you have in the denture. As we talked about, it's nice to make a recess in there. Place a physical undercut and a lingual vent hole. So whatever material you choose to use for your pickup, these are all giving you mechanical retention, in addition to the chemical retention of the material you're using. So these types of housings, you can sandblast, you can air particle or braid. All you're really going to do here is increase the surface area, which is a good thing. And I in particular like to use a metal alloy primer on top of it. So again, I'm getting mechanical and chemical retention here. And that is going to help everything to be picked up. So, let's talk about what happens if the prosthesis fractures. The most common place for the fracture is over the housing. So let's talk a little bit about the space requirement here. Excuse me. So a locator requires the shortest amount of height. The total height there is about 2.5 millimeters, and you need about 3 millimeters of acrylic above that. It doesn't show that in this picture, but this is just what I'm telling you from the prosthesis point of view. A ball attachment is going to require more height, probably about 5 or 6, because the ball's a little bit taller, and then you have the attachment with the O-ring on it on top of that. So think of it like this. Any type of overdenture, you're going to need significant amount of space for the attachment, whatever retentive element over it, the denture teeth and the denture base. So we're looking at probably 12 to 15 millimeters. I think it's almost the same amount of space as you need for a fixed restoration, maybe even a little bit more. But these patients that you're doing this treatment, usually these patients are coming in edentulous. Some of them are atrophic. So I don't see an issue with restorative space on these patients. That just happens to be what comes through my practice. And again, as I talked about, I think the framework reinforcement is really one of the most important things. So what we were talking about is whatever the abutment is, we need about 3 millimeters of acrylic over that just to secure everything in. So this is just my, menu of frameworks that I've done in the past. If you look on the bottom left corner here, this is actually from an article, which I don't have that quote in here, but I can send you the article link if you need it. This is an implant partial overdenture. I think this is an unsung hero and a very underutilized treatment for our patients. Patients who are missing a few teeth, but not a ton of teeth. The old school style would have been like a fixed roundhouse. That is certainly, phased out with the advent of implants. But if this patient's wearing a traditional RPD and, maybe they don't have the funds to get enough implants to have fixed restorations, or maybe they don't want to do a sinus lift, or for whatever reason, there's a barrier there, the addition of 1 or 2 implants in a posterior region, and you can pick that up with a traditional cast partial, is really a nice treatment and really a nice upgrade, because now they're going to get really nice retention from an implant that they're not going to get from a clasp. So the clasp is just resisting displacement, right? Displacement in a vertical direction. Now they're going to get retention. So that's a really nice item that you can get for those patients in that manner. So if you look at the bottom second photo, I don't have a pointer on here, I'm sorry. But that's an example of a bar overdenture with attachments on top of it. So that's also another way of doing this, a combination of locators, hater bar, and an implant bar. The picture to the right of that, it's a different patient, but it's the same idea here. There's a framework, locators, and a hater. And all the way to the bottom right, that is an ERA attachment, those black circles you see in the back, ERA and a hater. So it's all different ways that you can set this up based on the amount of space you have, based on the implant position, and how much retention you need for the patient. Okay, so let's go to this one here. So what about a patient who has pain on insertion of the prosthesis? So you can have 2 plane issues in 2 different planes here, both a vertical plane and a horizontal plane. And I find that most of this is related to the tissue and the prosthesis. It's important that you look at the intaglio surface of the prosthesis. Maybe that acrylic is overbulked and it's impinging on the tissue. And the way you would see that is if you look at the abutment around the implant. If it's very red and hyperplastic, something is irritating it. So you can certainly take an acrylic burr to that and then just adjust it as needed. So remember, it's just like an implant temporary. If you made it temporary where the margins were too long and you had too much acrylic subgingival, of course the tissue is going to have inflammation. So it's the same type of item here. Also, if you find that the abutment is too short, like the abutment is at the gingival crest or the subgingival crest, when the patient inserts the prosthesis, it's going to squash that tissue. It's going to be painful for the patient. On the other hand, if the abutment is too tall, then you're going to run into cantilever issues. But for this situation, you're really looking at the tissue. So your abutment, you want it to be super gingival so that the prosthesis can adequately sit on top without literally squashing the tissue. So let's talk a little bit about the abutments here. Again, this just happens to be this unsplinted abutment, and this is available in a range from 1 millimeter all the way up to 5 millimeters. So the transgingival height is exactly that. That should be between the platform up to the crest of the tissue. So the little cuff on the top, that 1.5 millimeter cuff on the top, that should be super gingival. That should sit about 1 millimeter to 1.5 millimeters above the crest of tissue. So Often in life, the tissue is certainly not even in a 360-degree manner. So the way that you want to select it is you want to go with the highest tissue. So you want that cuff sitting above all the tissue. So let me give you an example of the incorrect use of that. This was a patient that came in for consultation. Unfortunately, I never was able to treat him. I did not have my camera with me that day, so this is an iPhone picture. But you know what? I think it's interesting enough that I wanted to put it in my lecture, even though the picture's not amazing quality, but you get the idea here. This patient came in with the denture that sat on top of this, a high water denture that sat on top, and he said it doesn't fit. So, look at the abutments here. Clearly, these abutments were way too tall, right? And, poor selection of abutments, not obviously not a great treatment because the patient was uncomfortable and couldn't function. So again, the importance of putting the cuff at a little bit above the tissue height. Okay. Which leads me into our next thing here. Before we talked about ball abutments. In this particular case, this was a patient that came with the implant overdenture. So the denture fractured, and these are one-piece mini implants with ball attachments. So it's a one piece, which means I can't unscrew the abutment on top. So for those of you who have been in practice for a while, you know that these were certainly around maybe 15 years ago. And I think they kind of died off once we got to like early 2000s, right? Late 2000s. So this was the hype for a little bit. If you couldn't do an implant, let's do the minis. But the issue with the minis is, look at the tissue. So I would find sometimes they're placed too close together. In this particular case, this patient was on a number of medications. One of those side effects being gingival hyperplasia. You can see that right here. An elderly patient in her 90s and issues with hygiene, unable to clean this. So, what's the treatment plan here? The problem is we have 4 mini implants. Are we really going to remove everything and place new implants on an elderly, heavily medicated, when I say medicated, I mean polypharmacy medication taking patients? To me, that's very aggressive. The family just wanted to get her comfortable so she can eat. It's like a 94-year-old lady in a nursing home. So what I happened to do here, when I said I actually scanned the abutments, the ball on the top, so I could have my technician measure the width here. Because she couldn't give me any information on the implant, right? She couldn't identify the dentist who placed it, so she didn't have anything to tell me. So I had him measure it. I believe these were about a 1.5 diameter ball attachment. So he was able to select the component for me based on the diameter. So if you have a nice lab tech that's creative, you can put your heads together, you can solve a lot of problems that you couldn't before. Again, the advantage of the scanner, right? So what he did is he sent me like 2 different ones that he happened to have in his lab. I tried them both on. I let him know which one fit, and that's the one we used. So my periodontist tried to plane down this tissue, try to give her some hygiene instruction, give her an electric toothbrush, just, kind of work with what we have here. So one of the attachments is a little bit worn. I forget which one because it's not that clear in this picture, but like 2 of them were pretty worn. The other 2 had nice retention. So, my information to the family was, look, we're not going to do surgery on this lady. It's not going to be the most retentive. It has some retention, but not a ton. And we had to make her a new denture. So I made her a new denture with the frame, with the ball attachments. And she's able to, take that in and out. So that's that kind of situation. So look at this on the bottom. I gave a lecture on implant overdentures, ironically, to my residents today. So this is like my second overdenture lecture today. But one of the questions that came up is, what do you do with these patients with hygiene? Are they able to clean it? Or what do you tell them? So this is a patient who had a bar overdenture. You can see here in the distal, it's on a round ball. It's kind of like a flat top retentive element. The name of that attachment, I can't recall at the moment, but she had an implant overdenture for about 15 years. So when I took it out, of course I take a picture. Look at what's on there. Tissue was red, tissue was inflamed, and maybe she would brush it, but she wasn't given proper hygiene instructions. So that's extremely important, no matter what apparatus we have in the mouth, even a denture. So these patients, I'm telling them, you have to get an electric toothbrush, you have to use a water pick, You have to pretend this is teeth. You have to maintain this because this can have issues as well. So just an example of how things can accumulate. And there's our favorite friend that you already saw twice in the previous slides, and that's a little more close up. So these attachments can get plaque stuck in the center, and then it hardens, and then they can't get the prosthesis in. And I've seen that so many times. So again, hygiene is so important, as you can see here. Great examples of when people didn't have excellent hygiene. So, let's talk a little bit about how the patients should clean the overdenture. Can you do the soaking tablets? You can. But if you have anything nylon in there, any type of hater clip or retentive element or O-ring, any of those things, you want to instruct the patient to use a very short acting soaking tab, like a 1 to 3 minute. I wouldn't leave it for hours, and I certainly wouldn't leave it overnight. This is just a list that I happen to find online, just kind of ranking the toothpaste abrasion levels. So it's kind of interesting to look at the things that you wouldn't think are such an issue, obviously, are an issue. But they certainly want to invest in a denture brush to clean their denture. Even if they run it under water, it's important that they scrub it. And obviously, if you can use some low abrasive toothpaste to clean it, that would be nice. Okay, so another issue is when these patients have implants and restorations, they think they're great, they disappear. So they need to be educated that they need to be on a recall system just like you and me, just like everybody else. So what happens at that recall? However your protocol in your office, however you want to work it, whether you want to see them biannually, every 6 months, or if you want to see them once a year, whatever you think is right for that patient, I would check the prosthesis, check the soft tissue, sorry, check the soft tissue surface. If you suspect a real line, a really easy thing you can do is just take a little light body impression material, PVS, whatever you have, squirt it in there, insert the prosthesis. When you take it out, you can peel it out and look at it. I wouldn't use a bite registrations because it's too thick, it's too viscous, and that might get in the way. But if you use a light body, it'll work so well. It's important to check the occlusion. What if they're grinding their teeth during the day? Now they're going to wear the denture teeth, right? So you want to check the abutments. You want to check those for wear. You want to check those for retention, and also check stability. If it's loose, retorque it. What do you torque these abutments to? You want to check with the implant manufacturer. So each implant will specify what you should torque all of the components to. And that's important. And also, if you have anything in there, like a hater, a ball, anything that's nylon, you want to check that for wear. Look at it. Has it discolored? If it's discolored, it's deteriorating. It's time to switch it out. Do I routinely do this? I have them come in for recall and I look at everything. If something looks off or it looks like it's getting beat up, then I swap it out, and that's part of my recall appointment for these patients. I'm sorry, one last thing. We also have implants. It's important to do soft tissue, oral cancer soft tissue exam. It's also important to image your implants, not just the prosthesis. You can't forget about the implants, just like if you had a fixed restoration. So look at that bone level, monitor your implants, look at the tissue, look for any plaque accumulation. And often what we'll do is we'll put the prosthesis, we'll put it in the ultrasonic in the cleaner and do that for the patient while I'm doing my exam and working on the patient. So I just call this one day it stopped clicking in, because that's how the patients describe it to me. One day it stopped going in. And this happens more frequently than you would think. And I find it's often a result of tartar accumulation on the retentive element, and the patient can't insert the denture. Patients have come in and parts are missing. Sometimes the housings are missing. Sometimes the whole component is missing. Sometimes there's an issue with the abutment. And the other one that's kind of funny is some of these nylons, even the hater clip or the locator, they can kind of fold over on themselves. So the patient needs to be instructed to insert the prosthesis and to insert it with their thumbs. Don't bite down and hope it clicks in, because a lot of them will do that if you don't watch them. So careful instruction on insertion and removal is also important, because it can damage the components. So I've seen that happen where it kind of like folds down on itself, and then you have to replace the whole thing. So what I do is when things like that happen, either I'll charge for like a, recall appointment or an exam. If I have to replace parts, then I add that into my appointment fee. So, some of these abutments can get kind of costly. They can get up $100, $200 depending on what you're doing. So that's in my, that's kind of built into my appointment. Just an example, look what happened here. This person lost some elements. They even lost one of the housings. So they can come in all sorts of situations. This was actually the high water that I showed you before with the very tall abutments. So this is a big one. If the patient is coming in frequently, noting that it's loose, it's not clicking in, it's popping out so easy, I can push it out with my tongue. That's what I hear often. So, question them. How often do you take this out? If they tell you, oh, I take it in and out every time I eat something and after I snack, now you know they're taking this out half a dozen times a day, maybe more, depending on how diligent, how they are. I'm not going to tell somebody to put it in once and leave it in all day, but I'll certainly stress that you shouldn't be excessively in, out, in, out, in, out. Not only are you going to wear down the components, that's still stress on your implant, even if it is an integrated implant. If you've restored enough implants and you've done enough implants and you've been practicing a while, you know that implants can have issues. Implants do lose bone. Implants can fail. So why stretch them to their limit? So I tell the patient, wake up, put the denture in when you need to, take it out at night, and, try and limit it. You don't need to go in and out constantly. The other thing you might, question them about, do they think they're clenching their teeth? So they need to take this out at night, but maybe they're clenching during the day. Ask them, look at the teeth. If you see that there's wear on the teeth very early on in the prosthesis, you know something is happening. If this is, I don't want to say strong or weak, but if this is somebody who has a lot of dexterity and this is like a healthy functioning person, maybe you suspect that they need a stronger, retentive element. Like a frail elderly person with limited dexterity isn't going to need the strongest components. You're going to err on the light side. Where somebody more robust, maybe you're going to give them a stronger stronger retentive element, because they're certainly going to need it. And again, there's no rule book on that. I start off light on the delivery day. I follow them like a week, 2 weeks, a month. I see how they're doing. And that'll gauge me. Oh, it was really good in the beginning, but now it just pops out. So you know that you need to upgrade their componentry and the retention element. And again, that all goes by the number of implants you have, the position of them, and then look at the person that's in front of you. And that's how you can determine really what's best. Maybe patients were being changed from, traditional locator to the TRX. In my office, I have the legacy setup. I like it. I do very well with it. So for me, that's what I use. And the last thing here, we're blaming all these things on the patient. I'm going to put this a little bit back on us as clinicians. It's important for us to recognize when it's time for a new prosthesis, right? There is a thing called frequency, right? Maybe that's an insurance word. I don't like to think like that. But, let's be honest, over time, things will break down, just like a car. You can do the oil change, you can repair it. At some point, you need a new car. So the question is, when do you need a new car? If you see all that wear on teeth, and it's been a number of years, and the prosthesis is a number of years old, time to go, time to make a new one. Maybe you want to put a metal stop on the molar if you think the patient's a clencher. Just throwing ideas out here. If you're servicing this prosthesis, if you're relining it, and the big thing is if it fractures. If you have that framework, you're not going to have that disastrous fracture. But if you don't have a framework and you have a fracture over the housing or one of the components, that is that's a devastating fracture. And it's very difficult to repair that and get that proper fit. You really lose the integrity on the prosthesis when that happens. And once you start getting up there in years, look at the prosthesis. Soft tissue changes, bone shape can change. Maybe it's time to have that conversation with the patient. Okay, so just to kind of wrap everything up, I think this all comes down to, careful treatment planning if you're in the treatment planning stage and this is a new treatment for your patient. It's important to be involved with implant positioning with you and the surgeon, or if you're placing the implants yourself. Be precise. You want to place those implants in specific situations based on what you're trying to design. And again, it's important how you design your prosthesis with the metal reinforcement, the selection of components, and you want to have a good technician that you can work with, evaluate the restorative space. And I didn't say this because we weren't talking about fabrication today, but it's important to do a tooth setup first, and that's a big part of it here. And follow-up, right? Take the appropriate radiographs, check those implants, check the prosthesis, check the components. Whether you do this in your room, whether you have your hygienist do this, someone's got to look at it and stay on this patient and stress them that you need to come back and we need to check you. And patient education, big thing here. Just because you have implants does not mean you get away from us. You need to come in for that oil change. We need to check you. And they also need to take care of it. This is part of them too. They need to brush and maintain a fixed restoration. So why is this any different, right? It's not. It's just as important. And this type of prosthesis needs to be designed and treated with the same care and the same precision as you would a fixed prosthesis. And I say that every time I do this lecture. And every time I don't mean it, I couldn't mean it anymore. Okay, so there's my QR code on my Instagram. Sometimes I post links if I do some free CEs. I try and, but anyway, you can follow me there.